necessary, but you know who else I don't want making a decision? I don't want government making that decision either. I want you and your doctor making that decision. The only two people that should be deciding what's medically necessary for you is you and your doctor, not anyone else. No me and say, can you get me to this community? Can you get me into a hospital in Germany? Because they have a really good system, right? No one ever called me and said, can you get me to this community hospital because they need a heart transplant? They want to go to the best hospital in the world. Because when they have that incident, that catastrophic incident that can happen to you or your family, you want to go to the best. And you don't much care what it costs. However, we have to make sure that's available to you. We have to make sure we don't go out of business. So we have to make sure that things that are happening to you are absolutely medically necessary. That's why we put in patient education, so that you can be educated in a way that you can decide when to go to a community hospital, because you have those quality numbers. You can decide when to go to a teaching hospital. And if you feel your doctor, and this is unlike the 90s, you feel something is medically necessary to you that your doctor isn't providing to you, you can go to an Office of Patient Protection at the Health Policy Commission that Karen talked about, and you can get an immediate appeal heard. Because you should be able to say, no, I think this is really important. But what's happening now is patients are self-diagnosing. And doctors are so afraid of med-mal or being sued that they're just giving in. So somebody watches Seinfeld last night on television, they see a guy running through the fields and they say, that guy looks really happy, I want the drug he's taking. And they call the doctor and they say, I want that. And the doctor sometimes says, okay. Or they go in and they say, I think I need an MRI, I think I need a CAT scan. Well, no, you really don't. You really don't. And you know what? Maybe if you knew that a CAT scan was 240 times the radiation of an X-ray, you really wouldn't want it. But you don't get that information because we don't do disclosure. So those are the kind of things that patient education will do to put you in the driver's seat. Now, the reason why it's never happened before is because patients don't have skin in the game. There's no benefit. So I always use the example, this is like an open bar. Everybody's drinking and no one knows who's paying. So what happens in healthcare right now is that you can go and potentially get anything that you want. But because you derive no benefit, there really is no incentive for you to try to be healthy or try to limit your care to what's absolutely necessary. But through shared savings, through programs that allow your premiums to go down, and this bill, as Tom said, will save $200 billion over 15 years, but that's a big number. Forget that number. Listen to this number. 3 years from now, your family plan will be $2,000 less. That's a real number. When you're paying $20,000 a year in your family plan, and you could save $2,000 because we've put incentives and benchmarks in for the industry to meet, so they can no longer grow at 6.78%. That's real money. That's important. The next thing we look at is workforce development. We don't have enough primary care docs. Ben's absolutely right. We should pay them more. We should call primary care docs a specialty. We should pay them more. We should allow them to do more. Work to the top end of their license. We don't do that. But short of that, there are some other things that we should do, and we did do. We increased scope of practice for nurse practitioners and physician assistants. One of the reasons why you go to an emergency room, you collective, not you individually, is because you either can't get an appointment, you don't have a primary care doctor, or it's after hours. So you're left with no choice. So you incentivize limited service clinics to be open at night, open on weekends, where the cost of care is much, much less. You don't go to the most expensive place in the world where you don't want to wait 3, 4, 5, 6 hours anyway to get care. You go to some place where you can get care quickly from a nurse practitioner or a physician assistant. Then if you live in the western part of the state and you can't find a primary care doc, what we've done is we've incentivized primary care docs to go west of Worcester and to go out to the Berkshires, to Fairview Critical Access Hospital that has 25 beds. Next closest hospital is 41 miles away. They need to have primary care physicians in that particular area. Our tourism relies on it. People come over from New York in the summer to the Berkshires. The second question they ask after where they're going or when is James Taylor playing is, what am I going to do if someone in my family gets sick? Right? So we need to make sure that we keep these community hospitals alive with primary care docs. We have 3,000 primary care docs for 6.4 million people. Now, the problem is they're all located 10 miles from Boston. So we got to incentivize them through workforce development to get out into other parts of the state, and we do that through this bill. Now, the last big piece, payment reform, right? So all that low-hanging fruit that I talked about has nothing to do with the way we change paying for health care yet. But Karen talked about this a little bit. We pay for health care fee for service. Every time there is a service, you get charged a fee for it. Now, don't we all agree then that the incentive is to have more services? Dr. Atul Gawande from Mass General Hospital writes in the New Yorker all the time. He's got 3 great books on healthcare. But he talks about if you were a general contractor and you ran your business the way doctors run theirs, you would put 300 toilets in someone's house because you get paid by the toilet. Or you'd put 1,000 electrical outlets because you get paid by the electrical outlet. It's not the coordination of care that a general contractor is supposed to do. Well, your doctor is your coordinator of care. They're supposed to coordinate your care. The original idea around the global payment, and I understand what the studies have said about it, but those studies are based on global payments that have an underlying fee-for-service system, because all the contracts are still based in fee-for-service, is that we look at an individual, we come up with their personal health profile, and we figure out what it costs to treat them. And we treat them to the best possible health we can. And if we're successful, their premium goes down and the doctor makes some money through shared savings. And if we're unsuccessful, we reset the global payment the next year. We don't punish somebody. We just reset the global payment. And on a risk-adjusted global payment, your global payment is based on how your health starts, what your health status starts at. So what happens in that slide that you saw some of the urban areas that aren't seeming to get the same quality care, some of the affluent communities, they actually become attractive places to do business. Because in an urban setting with an unhealthy population, the risk adjustment, the delta on the risk adjustment is actually more. So you can make more money. So the byproduct of that system is that we get healthier as a community. Right? Scotland has figured this out. Scotland pays people if they have a low BMI, body mass index. They've figured out that if you are healthy, you are less of a risk to the system. You're better for the community as a whole. So we don't say that you have to use a global payment. We don't say that you have to use an accountable care organization or an ACO or an ICO or a CCO or any of this alphabet soup in healthcare that you hear about. What we say is you just can't use fee-for-service. What we say is over the next 10, 20, 50 years, there will be innovations in healthcare, and we don't want to stop that. But what we want you to do is move to a different system. I want you to move to a different system that puts the patient first, coordinates their care, and incentivizes them to be healthy. Now, the last piece we do, because you have every other industry in the last 5 years to a decade is growing at 2% a year. Some at 0, 2% a year. As Tom mentioned early on in his opening remarks, this industry grows growing at 6.7 to 8%, and slated to grow up to 13% next year. Right? So what we say is, you know what, enough is enough. You don't get to grow without any checks and balances. You got to prove why you need to grow. We set a benchmark at potential gross state product, which is 3.6%. And we say in the next 3 years, you need to meet that. All right? You're still growing more than everyone else. Everyone else is only at 2%, but we cut it in half. We cut your growth in half, and we ask you to prove, if you missed that particular goal, why. Did someone get better care? Was it a catastrophic incident? Or is it going to some of the administration that should frost all of us when we see some of the salaries that we see and some of the administrative costs that we see that don't go to your direct care? That is essentially what we have done. We've taken things that absolutely do not work, that all of you have experienced in your regular lives, and we've attempted to fix them. But we've done it through the lens of the patient, so that we make sure that you are protected. Your care is not rationed, you are not capitated, and in that time of need, you or your loved one can go to the hospital that you need to go. Because at the end of the day, it's about your individual health. And there's nothing that Speaker DeLeo or Chairman Santacandro or me or anyone else in the legislature was going to do to hurt the people that we care about. That's the bill. I am betting that it's going to work. I'm hoping that it's going to work, but it is better than what we had last year. That's for darn sure. So I think I'm the last speaker. I'm happy to open up to any questions or turn it back over to Tom.
Thank you. That was very impressive. What we'll do is we've obviously gone a little bit longer than we would like. I just want to take a couple questions, but I just have one question that I think, just to sort of give a more lay of the land for you, Stephen, is how does this play with the Federal Affordable Health Care Act? How does what Massachusetts has done, how does that interplay with that?
I think the nice thing that we did by doing the 2006 law is that we were fairly independent. So nothing that the federal government had done would have impeded our ability to still try to save you money and give you better quality care. Now, I think that what you will see more than anything is if this works, it'll be a framework for the rest of the country, and that would be exciting. And that's, by the way, one step closer to single payer or other things. You have to be somewhere to get somewhere. You just can't blow a system up and start a new system tomorrow. So this is a system that begins to move the leverage, as I said, from insurers and providers to patients and doctors. That's something that we all should be able to begin to agree on. And will we end up someplace years from now that's closer to what Ben talked about? We very well may. But it's steps. And the next step will be for this to be a framework for the rest of the country.
Thank you. Thank you. We can take a few questions from the audience. If you have a question, sir, if you could just walk up to the podium there, so they can get you at home on cable. So just go ahead.
Great.
Let her go.
First off, I want to thank you for all the effort you're putting into this. It's too bad I won't be around to see all of this come to maturity. Would have been great if you started 20 years ago, but that's here nor there.
High school.
Yeah. Well, I wasn't. One of my questions has to do with the payments that go to physicians or to drugs that you get. When I see that, for example, on my drug list, it shows that the total insurance price, as an example, would be $150 for a particular set of drugs. My copay is based on what I'm doing with my insurance. If I did not have insurance and I needed that same drug that the people say they can get it for, why could I not buy it for that price as opposed to some overinflated price because I was so unfortunate that I really couldn't afford it? That's one question. The other has to do with a physician's payment for whatever service he's providing, and that same billing that he would produce, it shows up on some of my insurance costs, are far in excess of what he's actually agreeing to receive for the same thing from Medicare and or the insurance. And if you can take care of that, great. Thank you very much. I'll sit down and hear what you said. I've said it.
Two excellent questions. There are three prices for any particular service: the price that you pay, the price that the insurer pays, and the price that the doctor charges. So you don't know which price it is, and that's what you talk about. After your copay, there's a particular price, then there's a price that they suggest is the price for that drug, and then there's a third price that is actually the contracted price. And a lot of those are dependent on the findings that the Attorney General had and who has the market power and who has brand to be able to negotiate better costs. We don't have an answer for that yet, with the exception of this. The disclosure and transparency section will shine a light on that in a way that it's never been shined before, and I think consumers are getting more savvy, like yourself, that they're noticing things like that, and it's becoming less of the norm that it used to be. I'll take my shot at the second question, then I'll turn it over the others for comments on that. Same thing with the physician. The physicians are contracted at a particular price. It is not the price that they necessarily charge. And all of that is based on the particular power of the group that they may work for. Different price for a ma and pa doc shop than it might be for a large provider organization, that it might be for Partners Physician Group. And it's all based on a negotiation. The only difference, again, with this bill moving forward than with what we have today is those negotiations are no longer behind closed doors. So you'll now know what that negotiation is, and there'll have to be some answers for that, I think, in terms of some of the excess that you see in some of those contracts. I don't know if either one of you want to jump in.
That's a good answer.
All set? Go ahead. Come right up to the podium, please.
Everyone. I'm a nurse practitioner. I've worked in public health here in Framingham and Ashland, and I've worked some of the major city hospitals as well. And my husband is a transplant patient, and I've been inside hospitals for long days like you. And I guess what my experience is that I would like to have my medical care and my husband's medical care decided between the teams and us for what is the best thing to do. I want the teams to help us be advised of what the risks and benefits are so that we can make the decision for the best medical care. I don't want the insurance company or the people who are the case managers to come and say, are you willing to absorb the extra blah, blah, blah cost when my husband is unconscious and in the ICU and needs an MRI to rule out a brain bleed, which could kill him? Yeah, I'm probably going to accept that. And was it my fault that I didn't, know what kind of brain problem he would have? I can't anticipate that. And I think that trying to compare me shopping for best insurance is like trying for medical care is not the right analogy to a car. You can choose to get a Toyota bottom line car. I love my Toyota. But you can also choose to get a Lexus if you can afford it. And that's not the same with healthcare. It's like choosing better, safer water or less safe water. You have to have something that's really gonna do exactly what it's supposed to do in the best possible way. So I feel like the question of us being consumers and knowing and all this stuff is not necessarily where it's at, you know? It is important to have, and I do appreciate you talking about transparency. You know, it's insane, all the different rates and everything. And I do appreciate the increased restrictions and the moves towards those things. But I think at the heart, still, when I go to the hospital, that we don't pass go without insurance. We don't pass go anywhere. And that is like, as we know, not very good for our lives. But then even if you pass, you just continuously get the burden like you needed to make that choice. You need to deal with this. You need to come up with the extra $100,000. Sorry. And you can decide in the middle of this terrible crisis, your baby being intubated, you realize that you're going to need to sign for this, that's going to be on your shoulders if your insurance doesn't cover it. It's like no choice at all. Of course you're going to sign. Your baby, right? So I just wanted to say that I really appreciate all this work, but I really do feel like ultimately it's a decision that I want to make with my patients, and that actually my care has been driven more and more by the finance of it all. What am I allowed to prescribe? What am I allowed to order? What are the patients allowed to, what do they decide afterward? I order a liver, ultrasound, and they refuse to go because they know it's going to cost them $700 and they don't have it. So I feel like we need to channel in forward. Does that make sense?
Okay.
Thank you.
So first of all, thank you for sharing your story, and hopefully you're as blessed as we are and things are moving in the right direction. But and I would just want to, having worked with the Attorney General's office and Karen, here's what I know. We don't trivialize this at all. We try to take a very complicated subject that you may understand based on your professional life and try to explain it in ways that we think can bring it down to a level that folks understand. I think the point that we're both saying, that Karen was saying about the cars, is that it's not a traditional market. And when it's a public good that has public money, it doesn't operate like a traditional market. I'll tell you, again, a story that we share. Apria Healthcare called one day, and I love saying Apria Healthcare because I'll do everything I can in my life to try to put them out of business and destroy them, and say that that my son had used up his lifetime supply of oxygen. Right. But here's the difference, I guess, with I guess being a savvy consumer or someone in the market a little bit. I said, okay, come pick up the oxygen. And they said, well, we can't do that because he needs the oxygen. I said, well, come pick it up then. I said, you tell me that I've used up my lifetime supply. Clearly, I said, and so then I said, let me be very clear. I'm not paying for it, so you can come pick it up, or you can leave the oxygen here. It's your choice. Now, we all know Apria Healthcare is not coming to pick up, but how many people do they take advantage of in those situations? So 2 things about this bill that I think are important, and none of it changes overnight. Absolutely, insurers' products are going to change over time. By setting up accountable care organizations or other types of coordinated care organizations, providers are accepting risk. What that does for you is it means that a provider, a hospital or a doctor, is helping you make decisions for your health care, not an insurer. And you're cutting out the 10%. You don't need to pay the 10% off the top. So there's additional savings right there. So your provider can make better choices for you because they are also the ones that are acting as your insurer. So you will see insurance products change quite a bit over time. You just saw Tufts Floating Hospital for Children offer a new product that they're going to be coming out with, a mutual insurance company. It's genius. Owned by the patients. Genius, right? You just saw Partners go out and buy their own insurance company, right? And you saw Blue Cross, who's actually a first mover in this market, set up their AQC2 product, Alternative Quality Contract 2, which is saving some money. It's better than the first generation that they did, and it's moving that leverage and that risk into the hands of the doctors. What hasn't happened before is doctors haven't been willing to take the risk. But I think our doctors today are saying, you know what? We want to be the ones making decisions for our patients. And I truly hope that you'll begin to see a change in that the more you go. I mean, it is pretty remarkable to think someone is moving into an ER on a gurney and they're being asked for their insurance card. And that is a problem, and we, we're supposed to treat first and then figure everything else out later. So thank you. It's an excellent point.
I echo Representative Walsh and thanking you very, very, very much for your story from the bottom of my heart. As a first-time parent, my son last year was diagnosed with a potentially fatal disease that afflicts less than 1% of kids. And so as a first-time parent, that was devastating initially. He was hospitalized for a week and doing great and on his way to a full recovery. And so the first thing I want to say is the conversation sometimes that happens at the system level when you have to govern an entire system, I certainly don't intend it and mean for it to be speaking to individual cases, and certainly that there are many that deserve, they all deserve individualized attention. And so I think certainly our particular findings, our office's findings, are meant to sketch out a landscape, help us figure out the wave caps and certain areas where there is low-hanging fruit and there is dysfunction and there is concern about where we can grab some excess in the most effective, direct way possible. In terms of the description of the market, certainly I agree with you. This is not, and will never be, like buying a car. I bring up the analogy only to speak to, if you want a functional market, whoever is sitting in the purchaser's seat has to have some basic information. And the incentives have to be lined up in a way where if you're doing a better job, you get paid more and more people want to go to you. And that's being disintermediated every step of the way in our system. And frankly, that's not going to change because insofar as in new systems, it will still be the health insurance company that is negotiating directly with the provider, right? In our new improved systems, it's still not going to be us individually, one-on-one, doing that type of direct haggling for the car at the dealership. This is all to say that I want us thinking carefully about what incentives the insurance company is facing. What incentives do they have when you look at that price waterfall to get you good value when they are taking your premium dollars and paying some providers more? Are they doing a good job making sure that we're getting good value for those extra dollars? Or are they taking, giving extra payments to those with, or additional payments to those with clout, and then turning back and passing that on through to you and your premiums, which just go up every year and you don't have a good idea of why? So I think this is a sector like no other, and how we can play our role as consumers is being educated, so generally understanding the system, and in the places where we can appropriately play a driver's role to do that. I want to leave you with one general thought as to an example of a place where I think us collectively could play a helpful role. It would not be in, I don't think we should set up a system where people are being pressured during a medical emergency when you're receiving a service to make decisions. That's not the right time to be asking someone to make a decision. So and something our office has talked a lot about is, can the consumer, can the patient play an effective role when they're signing up for their insurance plan? So in my case, we renew every year. Alex is healthy this year. We decide what type of insurance product we want to go in. It's not in the pressure cooker situation, an unfair situation where you're faced with a medical emergency, and you decide you want to try one of these new, innovative, more creative products that have been rolled out in the last 2 or 3 years, and that some of our laws now require insurance companies to offer you options, different insurance products. And one type essentially looks at that waterfall of 70 hospitals in Massachusetts, thousands of physicians, and it focuses on those providers that are highest efficiency, those that have great quality scores, great quality performance, and also do it for a lower cost. They're more efficient. If you focus on getting your care, if you're interested in getting your care from those providers primarily, then you will reap the premium savings. And being empowered to make a decision between health insurance products, to choose an insurance product with a lower premium because the network consists of the high efficiency providers, I think that's a really good place where we could be afforded a new and different type of a decision that we haven't been.
Very, very briefly, so, you know, there's a researcher at Suffolk, and I don't actually know if she's published this research yet, but her team did an experiment. If you buy health insurance through the state's Commonwealth Connector, through Commonwealth Choice, you get a choice of, it's called a bronze plan or a silver plan or a gold plan. Gold plan has a higher premium and then bigger deductibles and co-payments. You know, the bronze plan, other way around. So bronze plan has lower premiums but high deductibles, high co-payments, and vice versa. So they interviewed a bunch of patients who were signing up and said, you know, this is the plan that you take if you're healthier, this is the plan that you take if you're sicker, and asked them to try and make an informed choice based on their health status of which plan would be best for them. But then they took a second step. And they actually interviewed their entire health history for the last 2 years, every single service, every single drug that they had filled, and they costed out essentially how much it would cost them in co-payments and deductibles to try and figure out whether they made the right choice. Did they pick the one that would save them the most? And almost everyone got it wrong. Almost everyone picked the wrong plan because sometimes a diabetic who has their diabetes under control considers themselves to be healthy, but actually their health costs are much higher than average. So it's, in a way, I feel like there's an illusion of choice. You have to be like an actuary or a physician to be able to actually choose a plan. In most countries, patients are not consumers because it's not a market. Patients are just patients because healthcare is a right. It's a public service. I don't think patients should have to be consumers. And even this term, the healthcare industry, is new within all of our lifetimes, even the youngest of us here. We didn't start calling healthcare an industry until the 1980s or so. And it used to be that hospitals were all run by doctors who went up and became chief of their department and then became CEOs of the hospitals. Now they're all run by Harvard MBAs, and it's basically run like any other industry. And they use the same, lingo that gets used in all other industries for efficiency and so on. I think it just sort of dehumanizes the healthcare system. So I guess that's what I'd end on, is that I hope we can deconsumerize patients and deindustrialize the healthcare service system.
We've long run out of time at this point, so I want to thank you all for coming. I also want to thank this panel. It was phenomenal to see the expertise that you folks had or have. We have Ben Day, who is the current director of MassCare, and MassCare's mission is to that everyone in the Commonwealth have access to comprehensive, quality, affordable, and equitable health care. Karen Singh, who's an Assistant Attorney General in the Office of the Attorney General Martha Coakley's office. And then we also have Representative Stephen Walsh, who is Chairman of the Healthcare Finance Committee, who did a phenomenal job with the drafting of the landmark 2012 Cost Containment Healthcare Bill. I want to thank you all for coming here tonight. It was a great presentation. I think we all learned a lot. I am going to post the slides on the website, which is tomworksross.com, so you can take a look at those slides. But I want to thank you all for coming, for taking the time out of your day, and especially for this phenomenal panel who really did a phenomenal job in explaining where we are in healthcare, where we should be going, and what kind of issues we should be looking at. So thank you, everybody, for coming out tonight.
Thank you.